Our next speakers, we've got two talks. The first talk is by Sonia, Makhija, and Jim Bader, and they're going to be speaking about resolving uncertainty in suspicious occlusal lesions through practice-based research. The other topic is in pain. Don Nixdorf is going to do that one. We've tried to actually have speakers who've actually been through the process of doing research, so you're going to see them taking the idea from the science through to the research itself. So let me invite, Jim is going to start out, okay.
Good afternoon. I'm assuming that this mic works and I don't have to hold onto the lavalier for 5 minutes. Can you hear me? You can hear me, good. Sonia and I are going to describe 3 studies for you that have all been done within the network over the last few years. And these studies all focused on the same thing, suspicious occlusal lesions. We call them suspicious occlusal carious lesions, but we may revise the name soon. This is the object of our attention. This kind of occlusal surface causes consternation, if not uncertainty, in some clinicians. They don't know whether to do nothing, do something, do everything. And it is really an issue. Are there caries present? Has the carious lesion penetrated to the dentin? And we've got several examples of these. A couple of years ago, as a part of a larger questionnaire that was sent to all network members, we included this photograph and asked the network members, how would you treat this tooth? And we got over 500 responses. And here's the distribution of responses. 29% of the respondents said that I would do no treatment and no further diagnostic testing is necessary. We told them the radiograph was negative for any kind of carious lesion or periapical disease. 20% said I would do some preventive treatment, but that's all. 35% said, I'll do minimally invasive treatment with or without any associated preventive treatment. And 14% said, I would restore the tooth, full restoration, with or without associated preventive treatment. And then, of course, there's the 1% that said, I'll do something completely different. Those outliers are generally not paid much attention to. But here's the issue. What do you do with this kind of tooth? Suspicious occlusal carious lesions cause uncertainty, and they certainly, as we just showed, causes variation in treatment decisions. Despite this, there's very, very little in the literature that describes this lesion or what to do with it. It's one of those things where the uncertainty that dentists express, and my colleague Dan Sugars and I have known this for 20 years because we've been doing these kinds of studies, and this is one of the things that dentists always complain about. But it's never gotten back to the research community. At any rate, what do you do with it? Well, we have done 2 studies in the network and are starting the 3rd one that attempted to get some information about these lesions. So we're going to describe those. The first study involved 82 practitioners, and each of these practitioners enrolled 100 consecutive patients if the patient was eligible, and the only eligibility criterion was that the patient had 1 occlusal surface that was unrestored. If the patient was enrolled, then the patient was examined, and the examination was to answer these 3 questions we had. What's the prevalence of these lesions? I'm going to call them SOCLs for convenience. What were the characteristics? We were hoping we would get a definitive pattern of characteristics so that we could then say, aha, that's what one looks like. And how are they treated in these practices? Now, the practitioner filled out a consecutive patient log, which is really quite simple, and then if the patient was enrolled, filled out what's called a case report form that described whether the lesion was present, and if so, what it looked like. So here's what we found. In terms of prevalence, these things are quite prevalent. 34% of patients that had at least 1 unrestored occlusal surface had one of these lesions. 10% of all unrestored at-risk teeth had an SOCL. In terms of the characteristics, we weren't quite as lucky as we hoped for. Although 85% of the lesions expressed a dark color versus light, 55 were smooth versus 45% rough, 51 were shiny, 49% were chalky, and 52% were in the mandible, and 48% were in the maxilla, with 69% on molars. So we didn't get one single definitive pattern that would be very easy to identify. These things are all over the place. In terms of the treatment that were rendered to these diseases, to these lesions, 70% of the lesions that were identified were monitored. The dentist said, I'm not going to do anything, I'm going to watch this lesion over the next appointment or series of appointments. 16% received a sealant, and 14% received some sort of restoration involved cutting the tooth. Of those restored teeth, in 18% of the time, there was no lesion present when the tooth was finally opened. In 10%, the clinician judged the lesion to be inactive, and in 72% of the time, there was an active lesion found. Of those active lesions, 29% were confined to the enamel, and 71% extended into the dentin. So just looking from this step down here, you can see there is some room for improvement in our management decisions for these lesions. So study 1 was a cross-sectional observational design. Study 2 is a longitudinal observational design, and it takes 53 of the original 82 dentists, and they tracked the lesions they had enrolled at baseline for 20 months. That means there were 1,341 of these lesions that were followed for 20 months. And we were interested in the outcomes, what happened to these teeth in that 20-month period. And we wanted to know separately what happened to the ones that were monitored at baseline, those that were sealed at baseline, and those that were restored at baseline. So in terms of the outcomes of the monitored lesions, 90% were continued to be monitored the last time we saw them at 20 months. No intervention was deemed to be necessary by the clinician following that tooth. 6% of that group were sealed, and 4% had to be restored. Of those that were sealed at baseline, 6% had to be resealed, and 4% had to be re-restored of those that were originally restored at baseline. So to sum up what we learned from these two studies, suspicious lesions are really quite prevalent. 1 in 3 patients are going to have at least one of these lesions. And nearly half of the lesions that were opened didn't extend into the dentin, or were inactive, or weren't present at all. Nearly half, 48%. And if you leave them alone, a great majority of these lesions don't progress in the 20-month observation period that we had. So we concluded from these two studies that we need to develop some sort of detection method that would more accurately identify those lesions that were going to be, or that were already progressed into the dentin, because that is the standard of care today. It may not be tomorrow, but it is today for surgical intervention. So we have study 3, and I'll leave the description of that to Sonia.
Thanks, Bader. So Bader did a great job of explaining the first 2 studies and the results that we got from that. And as you can see, there was a lot of variability. And so that piqued our interest for the 3rd study, which I'm happy to say that pilot testing we've done and we're ready to launch this month. And it's looking at caries detecting devices. So what's the issue? Well, these caries detecting devices that are out on the market, they emphasize the ability to detect early caries. But however, the really crucial ability is really just to differentiate between enamel and dentinal caries. However, the research that we've got so far indicates that yes, these devices do work and they do detect dentinal lesions. However, there's a lot of false positives. So we're hoping with this study we can resolve some of these issues. In January, there was a Wall Street Journal article, and it looked at the caries detecting devices, and in particular, it looked at the canary system, which uses heat. And what they found for these early lesions, it correctly identified 93% of these lesions compared to about 27% for radiographs. So what they concluded, yes, these devices do work, but we need more clinical studies, and this is where the network is coming in. So what do we want answered? Well, our primary focus is to see, does use of these devices result in more or fewer lesions being treated surgically? And if they're being treated surgically, does the proportion extending into dentin increase or decrease? As Bader mentioned in our first 2 studies, what we found out is that almost half the lesions that were open were either no caries, inactive caries, or caries limited to the enamel. So this is a real problem. So I'm going to describe the study that we're going to be doing in our third study. So to begin with, before a practitioner does a clinical portion, they're going to do a pre-study vignette. And these are basically case presentations, and I'll show you an example of how you would treat a tooth and how likely that tooth has a lesion that is indentin. So and there are 16 scenarios. So after the pre-study vignette, the practitioner enrolls 20 patients with SOCL. They record the lesion characteristic, what their treatment decision is, and if they open them, did the caries go into dentin? And this is an observational study. It's the practitioner's decision on how they want to treat these teeth. So after they've enrolled the 20 lesions, they'll be randomized into one of 3 arms. The first arm is no device. They'll just enroll the 20 patients again, record the lesion characteristics, the treatment decision, and if the caries, how deep the caries were. The next arm is the diagnodent. Same thing, they'll enroll 20 patients, lesion characteristics, but this time they also add the device score reading of the diagnodent, the treatment decision, and how deep the lesion was if they decided to open it. And the third arm is the spectra. Lesion characteristics, they record the spectra score and their treatment decision and how deep the lesion was if they opened it. And then after they enroll these 20 patients, they take a post-study vignette, which will have the same scenario. We want to see if there's any changes in their behavior pre- and post-study. And they will also answer a post-study questionnaire on the utility of the device, if they got any information anywhere else. So this is an example of the study vignette. We found from the previous studies there are 4 main cues or characteristics that are very important. First is the patient's risk, the color of the tooth, the luster of the tooth, and the feel of the lesion with the probe or explorer. So we've got these 4 main cues, so we give a background on the patient, characteristics and tooth characteristics. They use a slider to see how likely it is that the lesion extends in a dentin and their preferred treatment for that tooth. Most of you are familiar with the diagnodent. It's a pen-type device. It measures changes in fluorescence. If it's a clean, healthy tooth, it exhibits no fluorescence, so you'll have a low reading. But if there's caries, there's bacteria, it will generate a higher number based on how deep the caries is. For the spectra, it also uses fluorescence. It's actually a camera that you go over the tooth, you freeze it, and it shows a photo of the tooth with both numbers and colors. It's almost like a Doppler, and it gives a range of sound enamel and all the way to deep dentin caries. And it can also be used if you decide to open the tooth and are removing the caries. It can also be used during the restorative phase to see if you've removed all the caries. So this study has a pre- and post-control group and also a randomized clinical trial because you're randomized into one of 3 arms. We hope to enroll about 3,600 patients. We've got 108 dentists across the network that are participating in this study. So each practitioner will enroll 40 patients, 20 in the pre-intervention phase and 20 in the intervention phase. And it'll occur in 2 blocks because what we found in the previous studies is that on average, practitioners see about 19 of these lesions per month. So we're giving them about 4 weeks to enroll it in each phase. So for a patient to participate in the study, they need to be at least 6 years of age, and this is on permanent teeth only. And the treatment can occur either at that visit or you can follow up with the treatment if you decide to do operative and need to reschedule them. So for the tooth to be eligible, it needs to have no radiographic evidence of caries in a dentin based on whatever radiographs you have available. But you do suspect that there's caries because of roughness, surface opacities, sensitivity to cold or sweets, or staining. And of course, you need to have no restoration or no sealant on the occlusal surface. So this is an example of our screening log. You approach the patient. If they decide not to consent, you just mark the reason and that's it. We don't take any other information. If they decide to consent, then you fill out this information on them. And then you or the patient completes a patient characteristic form. It's just basic information, age, gender, race, ethnicity. And then you do your dental assessment. So the information that we're looking for is color of the tooth, luster of the lesion, what age you used in making your decision, if you used any type of dental explorer, and then we ask some basic questions for the patient's risk assessment. And then you mark how deep you estimate the lesion to be, and then choose your treatment that you did. And if you did open the tooth, we wanted to know how deep the caries lesions ended up being. So we just completed our pilot of the study, and we got a lot of great feedback. We were able to revise the patient log to make it more simple and flow in your office a little bit better. We changed some of the photos that are in the operatory. You can it uses it as a prompt to enroll these types of lesions. Also, when you're consenting patients, it's good to show them the types of lesions that you're looking at. We've revised the training manual so that when the regional coordinators come and train you in the study, it's a little bit more easy to understand. And we revised the vignettes to make it simpler to fill out. So we're very excited about getting the results from this study. From the studies 1 and 2, we had articles in Caries Research, in JADA, and most recently we were the cover story for the November 2014 issue of JADA. So this topic is really important, and we're excited to see what the results are. So.
Thank you very much, Sonia.